saying don't use ibuprofen. Don't use ibuprofen for the first 8 weeks or so of the UK pandemic, we're also saying don't use certain other drugs. And that's illogical, because both the use of both of those sort of groups of drugs is based on thin observational evidence. And the whole ibuprofen thing is interesting because that really stemmed from a comment from a French health minister, which stemmed from a comment from an ICU doctor in Paris. So we really need to have a very open discussion about such things, how we use drugs in pandemics that are unproven, because it will happen again at some point. And early in the pandemic, people will want to use drugs that they think work, but may not work, and may be a risk to patients. So it's an important aspect, I think. And then, for me, there's the whole clinical trials issue. So we've been incredibly successful in the UK from the research perspective so far, and particularly the recovery trial, which is the really only trial in the world so far that has shown any positive pharmacological intervention for COVID-19. So you have to say that up front. Recovery has been a great success. I mean, we've recruited lots of patients in Hull, and many of the centres have recruited even more around the UK. So it's been a great success. But if you go onto clinicaltrials.gov, for example, there are, and that's not a UK-based website, that's a US-based website, but it's a trial registry, essentially. There are actually 48 trials registered that are looking at some aspect of corticosteroid use, i.e. similar to dexamethasone and COVID. So I would just suggest at a global level, not a UK level, a global level, is that really efficient? Is it really efficient to be doing so many trials relating to the one drug? And could, with more global cooperation, could we have actually got to the positive dexamethasone result earlier than we actually did, and also the negative results relating to hydroxychloroquine and the HIV drug Kaletra? So I think that is important future consideration, and indeed relevant to this pandemic. Global cooperation on trials. The bigger they are, the quicker they are, the quicker we get the answers for patients. And then, of course, there's been a lot of discussion about inequalities during this pandemic, and this is the very nice data from Ben Goldacre's group from Oxford, just published in Nature, and showing the relationship between various inequalities, age, comorbidities. We've all discussed the issues relating to ethnicity and indeed deprivation as well. So I think what's really important about this sort of data, though, is we really need to understand what it means. We really need to get to the bottom of causality here, because actually we don't do anyone who's suffered an inequality any service at all by not really understanding this sort of data well. And if we don't understand causality, and we need to do the high quality research that allows us to get to the bottom of that, if we don't understand causality, we cannot possibly put interventions in place that are successful in tackling these problems that clearly need to be tackled. And then final couple of slides. I think it's important that we think about the bigger picture, the link between the pandemic overall and other global issues. And I've used global health threats here as an exemplar. So, for example, the relationship between the pandemic and overuse of antibiotics and drug-resistant infections, which is a massive top 3 WHO health priority over the last decade or so, particularly over the last few years. And then also, on a more positive note, the decreasing human activity during the pandemic and how that may have positively impacted the environment. And of course, there's a relationship there between the environment and infectious disease epidemiology, and also possibly the emergence of pandemics in the future. So how we put the bigger picture together, how we understand the bigger picture and what that sort of informs us about, I think is really important. Now, I don't have the answers there, but I think it's important we really think about it as a global society. And this is an amusing little paragraph from a letter published in one of the papers, which I'm not going to read out for you. I'm going to allow you to read that, but it amused me, and maybe a little unfairly, I think it probably does say at least something about the UK's response to the pandemic. So thanks very much. I hope that's been interesting to you, and I think hopefully the other speakers will build on that, maybe in more specific areas.
Thank you for that. I was going to say, if anyone has any questions they would like to ask after the speakers or at the end. If you'd like to say them now, we can say them to the end, or if you want me to read them out, if you message in the chat below, I can read them out for you if you don't want to talk. But if not, we can go on to our next speaker, Edelweiss Shi. Thank you.
Thank you. Hi, everyone. I'm going to share my screen as well. I think I'm a bit different from the previous speaker because I'm from Department of School of Geography. So I'm more from the social science backgrounds rather than medical ones. And I have a background being taught in China, so I have a specialty on Chinese issues. So I'm going to focus on the spread of the COVID-19 and the changed population movement in China, and to see how the COVID-19 actually reveals the changes that have occurred in the society at large over the past 2 decades as compared to the spread of SARS 2 decades ago. This is the graph about the newly confirmed cases in China from the January the 15th until the March the 6th. And what is interesting here is that you can see there's a rise in the newly confirmed cases from the January 15th until kind of the first week of February. And during this part of the rise is the Spring Festival travel in China, which is quite equivalent to the Christmas season in the UK. So during that time, people are coming back to their hometown to gathering together with their families. So there's a synchronization with the rise of the confirmed cases and the Spring Festival travel. But if you say like what is Spring Festival travel in China, if you Google it, then usually you will get this kind of title saying that it is 3 billion journeys was biggest human migration begins in China. And about migration, there's a general picture of billions of Chinese kind of crowding into a train station and taking the train back to their hometown. And if you zoom in about what kind of person they are, the general portrait of this person are domestic migrant workers who used to grow up in the rural part of China and then migrated to urban China to work, but they return back home like once or twice a year to gather with their relatives back at the hometown. Because of the synchronization of the rise of the COVID-19 and the Spring Festival travel, and because of this kind of portrait of migrant workers during the Spring Festival travel, so people in China initially kind of relate the spread of COVID-19 with this type of person and tried to blame them of spreading the virus so fast, so far, and so quickly within China, just like within 2 or 3 weeks. But my research is about whether it is really true that the migrant workers are the ones that should be blamed for spreading the COVID-19 in China. First, we see this map here. It is a cartogram that is resized by the newly confirmed cases in January the 21st, which is really at the initial stage of the spread in China. The size is proportional to the number of confirmed cases of COVID-19 at that time in China. And the color is the our migration of these places to the epicenter, Wuhan city. So actually the darker the color, the more connections of the city with the epicenter in migrant workers. So at the initial stage of the spread, you can see that Beijing, Shanghai, Shenzhen, Chongqing, the 4 big cities got the most cases in China. However, Beijing and Shanghai didn't have a lot of migrants to the epicenter. They still got really high number of cases at the initial stage. Actually, the 2 cities, Beijing and Shanghai, have ranked constantly high in the confirmed cases throughout the whole period of the spread of the COVID in China. The ranking out of more than 300 cities in China. The ranking of Beijing was within like 30 throughout the whole period, and Shanghai was within 50. So these two cities are actually, we can say, is mega cities, is business, or the business hubs in China. So they do not really have a huge connections of the low-end migrant workers with Wuhan, but they got really high-end business trips or travelers between the two mega cities and the epicenter. In that sense, we can say actually the low-end migrant workers are not the ones who really initially carry the virus to different parts of China, but probably the more active business trips, business travelers are the ones that carry the virus so fast to every provinces already fasting within China. And also during the Spring Festival, we can see cities that have strong connections with Wuhan in migrant workers do see a huge increase of the confirmed cases, like these kind of counties next to the red area here. But however, we can also see these circles like Xi'an, Hangzhou. These are the capitals of these provinces. They do not have a lot of migration to Wuhan, but they still got a huge number of cases during the Spring Festival. The one reason is that these kind of capital cities of each province have strong economic connections with Wuhan, but probably not very strong migrant workers between Wuhan and these cities. So in that sense, the migrant workers probably do not be fully responsible for spreading the virus to a large scale. And also we can see within an island, which is Hainan Island in China, it is a red dot here. It is quite equivalent to the Isle of Wight in the UK. So in this island, they've got several cities within this island. And the seaside resort got the most confirmed cases in this pandemic. And this seaside resort has only a population like 700,000, and the migrants to Wuhan is less than 1,000. In comparison, the capital city of that province got fewer confirmed cases, but they got 3 times of the population of the seaside resort, and the migration to Wuhan is more than 10 times of the seaside resort. So in that sense, actually, the more travelers you got, the more confirmed cases you have in this island. And if we look at the Lonely Planet description, it is saying that this island is the Hawaii of China and also Moscow on the South China Sea. So it is quite popular among the Chinese as well as the foreigners as a tourist destinations. So in that sense, actually, the migrant workers were not the ones who brought the virus to this island. It is the travelers and tourism that brought this virus to this island. So given the previous 3 slides, we can say that actually the large scale is probably partly due to the Spring Festival of migrant workers, but it's not wholly due to them. And also the very initial spread of the virus that is so fast is probably due to the business trips, and also the really wide spread of virus in China is probably due to tourism rather than due to migrant workers. And we can see these things by comparing the geography of COVID-19 and the SARS. So here is the spread of the COVID-19 in China at the initial stages from the Wuhan, and then it spreads quickly around China. And we can also see some dots in really remote places like Tibet and Xinjiang are really far north of China. So just within 1 month, even before the Spring Festival, before many migrants were returning back to their hometown, we can see these remote places already got some confirmed cases already. But as compared to SARS, even after SARS has been spotted, 6 months later, these remote places haven't reported any SARS cases. So actually, if we compare the spread of the 2 viruses, we can see
COVID-19 is spreading much wider than the SARS, and also to much more remote places than the SARS. And this is related to the growth of different movements, different mobilities in China. As compared to 2000, in 2019, the level of migration in China only only doubled. But if you see the internal tourists in China, it was increased by 8 times for the past 2 decades. And if you see the civil aviation, the airlines, which carries so many business people and travelers, it increased by nearly 10 times. So as compared to the migrant workers, actually the internal tourists and business trips have increased far more in the past 2 decades than the migrants. And it is more deeply related to the change of the China's economy. So China used to be an export-oriented economy, which requires a lot of migrant workers in urban areas to work in factories. But for the past 2 decades, China has been transforming from this kind of export-oriented economy to a consumer economy, which means they encourage people to consume things, to travel, to do all this kind of to do all these kind of activities. So in that sense, actually, it is in accordance with the global change in the modes of consumerism, especially after the 2008 economic crisis. And also, if we see all these some of the companies of these kind of trendy stuff, the Airbnb was set up in 2008, and the Uber was set up after in 2019, and in 2009 as well, the Lonely Planet got a new magazine called Lonely Planet Traveler. So all these kind of things saying that actually after the economic crisis of 2008, the tourist industry actually grew exponentially worldwide as well. And also, like in the UK, many of the cases were actually brought by the British, who actually traveled to Spain to have their kind of holiday and then came back to the UK. And if you think about the first person who in the UK who got infected, he actually had a conference in Singapore and then went to France for ski and then came back to the UK. So it is really more related to the fundamental changes we have experienced for the past 2 decades. That is a change that more related to the consumer kind of culture worldwide. And that's approximately all the things I want to talk about. Thank you so much.
Okay, thank you. Do you want to move on to Dr. James Lomas, sorry.
Sure.
Yeah, and again, any questions? I think we'll wait to the end. I think it makes more sense. And I'll read the ones out.
Okay, so here we go. Just checking, can you see my slide there? Take that as a yes. Okay, so I'm James Lomas and I'm a research fellow at the Centre for Health Economics. Quite different to the other 2 speakers so far in that, to be honest, this is not an active research area of mine. So I'm more just commenting from the perspective of a health economist without too much sort of hands-on experience within this issue. Although, of course, like everyone participating on this, I'm sure I've been, keeping up with the news and stuff like that and have obviously developed some thoughts. But I'll try and keep it as objective as possible as I go throughout this. Okay, so I'm going to start on safe ground and get more and more risky as I go on. So start off as safe as it can go. I'm going to talk a bit about the type of health economics that we do, and then we'll talk a little bit about how that applies to some issues with COVID. So the bread and butter of what health economists working on economic evaluation do, such as myself, is we are interested in considering a new drug that's been launched and it's more effective than the current standard of care, but it's also more expensive. So health economists work really hard to try and work out how much more effective is it and how much more expensive is it, and to try and quantify that trade-off. And then ultimately we want to make a comparison between this trade-off with the new drug compared to standard of care versus what else could be done with this money. So there's a few images here. It's a bit of an image overload at the bottom of this slide. You can see bottom left is sort of standard economics, dealing with scarce resources and infinite wants. That's clearly relevant here. We've got a want for a new drug, but we've got limited resources, so have to make a difficult decision. We're applying it to the NHS, and the NHS is resource constrained, as any healthcare provider would be. And basically what this image shows is that once we approve a new drug, the effect of that new drug getting into the bed, as it were, will be that ultimately there has to be something displaced in order to fund that new drug. And that's the sort of principle behind a lot of the economic evaluation that we do. Another really important principle is this bottom right, which is to say that as health economists, we're concerned with, as I've talked about, effectiveness and cost effectiveness. So while a lot of studies will report findings about efficacy, which is maybe how much better a drug performs on a specific health indicator. I don't know, just an example like blood pressure, not a COVID example necessarily, but what we're interested in is translating that into a generic measure of health and then thinking about how much of a trade-off there is for the additional expense of that drug. So that's the bread and butter. So how does that compare with what we're talking about with COVID? Well, there's some additional challenges. Many of these are challenges with a lot of the things that we tend to evaluate in health economics, but anyway, I'll talk about them in the context of COVID. First thing is to say that I used the word drug on the earlier slide, but really, you know, health economics has quite a lot to say about other things that we're not as experienced in dealing with. So, as I say, the focus is generally on treatment strategies, sometimes prevention, such as vaccines, pharmacological form of prevention. But perhaps health economics has lessons to learn in terms of how do we evaluate preparedness of health systems for public health emergencies and pandemics, the topic of today's meeting. So it's actually a case that an economic assessment was carried out on stockpiling PPE. I think this was in about 2017 or something, and this was reported by The Guardian. And basically the cost effectiveness analysis that was undertaken by the civil servants found that it would be too expensive to stockpile the PPE at that point in time. And obviously that's had unforeseen consequences, largely unforeseen perhaps consequences that we're now experiencing now. And I think that that's an interesting example of how economics, perhaps it wasn't the wrong decision at the time, but it certainly looks regrettable from the point that we observe this decision right now. What else? Well, as I discussed earlier, we talk about drugs being launched. Now, the launch stage of a drug is a specific stage quite late on in the life cycle of a new drug. But in the context of COVID, we're actually talking about drugs that are at various stages of development. So dexamethasone's been around for a long time, that was talked about earlier. But also we're interested in perhaps brand new treatments that are nowhere near ready for launch yet, currently being conceived of. And an interesting question for health economists is how do we create the correct financial incentives for the development of new effective medicines? And this is something that's been talked about a lot by other health economists. For example, here there's this lecture recently on how the world should pay for a COVID-19 vaccine, which is clearly a very important question for us all and requires a lot of thought on the health and economic side of things. And then this has been touched on by the other speakers, so I won't talk too much about this. And to be honest, I don't think this is unique to COVID, but what it's really brought into the sort of mainstream eye is just the scale of health inequalities in the UK. And these disparities exist along several different dimensions. I thought Gavin's figure presented this really nicely. In addition, I'm not sure that air pollution was one there, but there's some quite strong effects observed between COVID mortality and air pollution, for example. So this is something that, again, like when we're evaluating our bread and butter new drugs, sometimes we don't necessarily delve into the sort of unequal effects that that new drug will have. Perhaps we should, but certainly in the case of COVID, I think it's something that you can't really ignore. It's really in your face, the fact that there's such marked inequalities in the effects. I mean, my hometown where I'm from has had more than 1 in 1,000 people have died there due to COVID. So it's, you know, it's a reasonably deprived area. So it really brings into stark sort of perspective all of these issues. I think that health economics does have a lot to learn from this, but we have some comparative strengths as well. So I wanted to go through those before venturing onto the much less safe territory of economics and macroeconomics for me. So we're known as the smiling face of the dismal science, of course being economics. And I think part of that is because we're quite friendly and do a lot of interdisciplinary work, which puts us in a good position for COVID because we're used to working with epidemiologists, clinicians, and so on. And that means that work with epidemiology, we're used to looking at infectious diseases through dynamic modeling and so on. And so health economics does have a lot to say, I think, in some of these questions that I've mentioned. Health economists tend to be quite humble. We kind of present our analysis and then leave it up to decision makers as to what they want to do. We're not necessarily prescribing what's the best thing for social welfare or anything. It's more kind of sticking to like, this is what the effect will be on health. It's up to you how you trade off various things. Different health economists will have a different perspective on that, but that's my own. But clearly from the questions that I've looked at just now, those of you that know economics will see that there's really quite a microeconomics focus of all of those questions. But I think we'd agree that the pandemic doesn't really get much more macro than that. I'm not saying that those microeconomic questions aren't relevant, of course they are, but I think we have to think about macroeconomics as well. So this is the less safe territory. So just to sort of highlight really, these are papers that I've got absolutely nothing to do with, but ones that I've come across recently. There's a number of papers out there. I think that there's been a huge number of papers published now on epidemics and pandemics by macroeconomists. And this one here is one that you can see, it's out in March or April 2020. But it's kind of a classic model. It's really well explained and I recommend reading it. It kind of talks to the issues quite clearly, I think. And one part of it that I think is pretty nice, seeing because I've talked about vaccines already, is just this little part here where it talks about the various optimal responses you might have to a pandemic. And it says that with vaccines as a possibility, it's optimal to immediately introduce severe containment measures to minimize deaths, causes a large recession, but it's worth it in the hope that the vaccination arrives before many people get infected. Now, clearly, this is at a very abstract level, and I've just highlighted this one because I think it's quite a clear message and relates to what I've mentioned in terms of vaccines. Obviously, the prospect of a new vaccine is highly uncertain, so I'm not necessarily saying that this is the way to go, but you can just see that these models have key insights for different policies that you might adopt. Given different circumstances that you face. They can be quite interesting. So these are the big questions. I suspect that when a health economist was recruited to this panel, you might think that they'd have an answer for whether a lockdown is a good idea or not. Unfortunately, I don't, but I think it's a very interesting question. And what I think is important to know is various trade-offs that might exist. So COVID has undoubtedly precipitated an economic crisis, but the problem is that there isn't really a control group in a pandemic. You know, everyone's affected by it, so we don't know that easily what is specifically responsible for the effect on economic output. So it's been mentioned earlier that Sweden is often the sort of comparison that's mentioned. Well, Sweden hasn't necessarily had a formal lockdown at the same time as other countries, but its economy also suffered a big recession. So it's hard to kind of pull these things apart because there isn't really a true control group in this circumstance. However, one thing I just wanted to talk on sort of methodologically is that often these policies are modeled and there turns out to be some sort of trade-off between wealth and health. And I just wanted to flag that economists are going to struggle with dealing with this trade-off. This little snippet here from a Harvard group talks about value of statistical life. Just to highlight here, it says the value of reducing mortality risk is based on an individual's willingness to exchange their own income for small changes in their own risk, such as a 1 in 10,000 decrease in their chance of dying in the next year. Now, economics is founded very much on looking at marginal changes and effects at the margin. I have a bit of a doubt as to whether we can still use that same machinery when we're talking about something that's so not marginal as a pandemic and the kind of economic effects that we're observing right now. So this is another challenge. I'm not saying we need to throw the baby out with the bathwater, but just to say that there are perhaps things that need to be developed within economics and within health economics to deal with this precise question. And then finally, I'm a bit of a person who likes to think about health over other things, as you might expect as a health economist. And it has even been brought into question whether there is a health case for lockdown. Obviously, a previous slide said, is there an economic case where there was this idea of a wealth and health trade-off? But some authors, and these are very good health economists who I know quite well, some of them, they're pointing out that there are these significant health effects from lockdown policies. You see here, evidence of avoidable non-COVID-19 deaths is mounting: cancer deaths, measles, women dying in labour. I think these authors have taken a global perspective, but we know that this kind of thing is happening in the UK through the reorganisation of the health service. So I'm not saying that it isn't a good thing to do what we've done in the UK, but it is a relevant question to ask as to sort of what are these other health effects that various policies might have, and therefore which policies look good from a health perspective. Okay, so my summary, as I said, it's not an active research area of mine, so I'm really just trying to provide a sort of perspective on this and maybe pose some interesting questions. We certainly don't have all the answers. I do think that the health economics toolkit will remain useful, especially in certain contexts where it's very well designed. But some of the bigger questions posed could require major changes, I think, in economics and health economics, both in terms of how we evaluate pandemics and pandemic policies, but also how we change our toolkit going forwards in the post-pandemic world. So thank you very much.
Thank you very much for that. And Dr. Joao.
Okay, thanks. Good afternoon, everyone. I'm going to speak about the politics of this pandemic. And I think it's fair to say, and this in a way summarizes what I'm about to present, is that this pandemic is partly the result of a political failure. And what we're witnessing, what we're living through at the moment, is the result of a failure of politics, failure at different political levels. And so I want to substantiate my argument by focusing on two levels of this politics of the pandemic. On the one hand, I want to argue that there was a failing at the level of global health governance, so the politics of global health. And then I want to argue that this constituted a scenario upon which you can see the failings of certain national level governments. And I'm looking in particular at a case that I've studied in more depth, which is the case of Brazil, which is now considered one of the examples of what not to do during a pandemic of this nature. So I'm going to look specifically at the political dimensions. So starting with the global level, or the level of global health governance, I want to suggest, perhaps a bit cheekily, that one of the reasons why we as a global health community have dealt so badly with the COVID-19 emergency is that global health governance has become too fixated on emergencies. By this, I mean that global health governance has become very reactive. focused on crisis management, focused on disease containment, focused on firefighting. So this is a short-termist mode of response, a myopic mode of response, if you want, that has meant that not enough attention has gone towards addressing disease determinants. Not enough attention has gone towards addressing the underlying conditions that enable these emergencies to occur and that hinder our ability to respond, our ability to bounce back from these diseases when they occur. Not enough attention or too much attention given to the major emergencies of the day also means that not enough attention is being given to the so-called everyday emergencies or the problems that our people are facing on the day-to-day. And James' slide, one of his last slides, was talking about all of these other health issues that have not stopped because of COVID-19. They are still entailing a huge burden in terms of morbidity and mortality. They're causing a huge socioeconomic burden as well. And these issues are not given sufficient attention. And these are what I would call the everyday emergencies, where people are faced with on their day-to-day lives. And this is not simply about other morbidities, it's also about socioeconomic conditions. Poverty is an everyday emergency for millions of people around the world. Lack of access to safe water, lack of access to sanitation infrastructure, lack of access to health education, health information. All of these are emergencies that people are faced with. And my argument is that we as a global health community have not paid sufficient systematic attention at the global level and in a cooperative way with these problems. And this means that we have become too fixated on the fires as they erupt. Obviously, we need to put out the fires when they occur. And obviously, we need to be addressing and responding to the health emergencies. But if we are only being reactive and not proactive enough, then we have a problem in global health governance. I would say, and I think perhaps here Gavin is the person to speak a little bit more about this, that we haven't done in global health governance, we have been very proficient in focusing on single individual diseases. We haven't been doing enough in terms of studying comorbidity or the syndemics, the coexistence and interaction of different epidemics and the effects that this has, not just in terms of human health, but also in terms of its broader socioeconomic burden. I think there's still a very much in global health, at least I think, there's a very much disease focus. And this kind of, sometimes we miss the forest for the trees, we miss the interactions between diseases and the way in which diseases work and function and circulate in ecosystems and in the connection between humans and non-humans. So I think there needs to be a sense in which we need to conceive health as being planetary in a broader sense. And the way in which we respond to health must take into account this broader, this larger canvas. We're not talking specifically about diseases, we're talking about diseases as they circulate and interact in ecosystems. So this failure to see health as truly planetary is, I think, one of the major failings of global health governance. So there is a narrow view, I think, of health as the absence of a disease in the human body or inside human bodies, which I think needs to be questioned and needs to be problematized. And I think certainly we need to rethink our mechanisms of governance at national and global level in order to really capture this problem, which is bound to become more urgent as we come to terms with the impact of the Anthropocene, the impact of human activity on the planet, and how it is impacting upon and will continue to impact upon human health to the point that it will endanger human survival. So I think we need, on the one hand, we need to think about this question of the planetary health. This is one of the failings of global health governance. I want to now switch to another issue which kind of touches upon Jim's thematic area, so to speak, So correct me if I'm wrong in any way, James. But I want to argue that the political economy of health and disease is very important, and particularly the way in which global health governance has been, specifically in recent years, increasingly shaped by a version of global capitalism, which is, as you know, neoliberalism. And what neoliberalism has meant, so if we understand capitalism, as I will, and feel free to disagree with me, but I would define global capitalism as a socio-economic organization that's based on the incessant growth, consumption, and waste. Then neoliberalism, as its variant, is based on deregulation, privatization, the hollowing out of the state as a public service provider, the hollowing out of health as a public and collective good. Now, this has meant, and my argument is that global health governance and global health, the global politics in general, has made us unprepared for events such as of this nature. We are currently unprepared. We are currently rendered vulnerable to events such as COVID-19 because of this trajectory of global health, and particularly the influence of neoliberal capitalism. I'm not arguing that it's only neoliberal capitalism that has led to this. There's other destructive dynamics that I could point out: colonialism, environmental destruction, racism, patriarchy, etc., etc. But I want to focus particularly on the destructive effects of neoliberalism. What has this meant? A weakening of public health systems, a precarization of people's livelihoods and people's economic situation, a precarization of work. This is not simply the precarity of health workers, although it's important in the case of the COVID-19 response, in which many workers are themselves operating and working in situations of great vulnerability because of meager salaries, because of insufficient job security, because of lack of protective, personal protective equipment, etc. So there's a general sense in which precarity of work and precarity of working conditions. And finally, the absence of social safety nets that has meant that situations such as lockdown or social distancing measures have had such destructive effects on the economies and on people's income and people's livelihoods. So all of this, I argue that there is a process of global vulnerabilization that is in part connected with neoliberal capitalism. And that has meant that people are, or some groups, again, the point that James was making, and I think other presenters have made about the inequalities here, that have made certain groups particularly vulnerable to being infected and in a situation of low resilience, of low ability to react or bounce back if and when disease occurs. So these are people whose life is completely turned upside down if they become ill or when they become ill. Where others may have a cushion, may have a safety net, many groups do not have a safety net. Okay, so there's this process of global vulnerabilization. There's a process of kind of a failings of the political imagination of seeing this as a problem of planetary health. There's also, I think, in recent years, a retreat of multilateralism, a retreat of international cooperation. And you may see that you have many governments these days returning to a kind of a nativist, isolationist perspective. And we are suffering a lot from the effects of this retreat of multilateralism. One example being the attacks on the WHO at the height of this pandemic, with the United States, for example, pulling out its from the WHO. But you could also argue that the problems that the EU is currently facing right now, the lack of solidarity between the different regions of the EU, the lack of a coordinated response between the UK and the EU, when there's so much that could be gained from closer cooperation. So in general, there's a failure of multilateralism, a failure of international cooperation. So this is kind of the general scenario. In the time that I have left, I want to look specifically at the national level. And here I want to use the case of Brazil, which is something a case that I've studied in the past few years. And as you know, Brazil is now widely regarded as one of the epicenters of the pandemic. As of today, Brazil was second in number of cases, second in number of deaths as well. We had around 2 million notified cases and around 75,000 notified deaths. Mind you that because of subnotification, figures are likely to be much higher. According to some studies I've heard, in some regions of Brazil, you may have subnotification of cases of around 700%. So the real number of cases may be 7 times higher than what is officially notified. And the similar studies have been done for deaths, which the real number of deaths may be 200% higher, or in some cases even more in Brazil. So the situation is dire. In order to understand what went wrong in Brazil, I think it's important first to look at the epidemiological profile of the country. It is a country that's a vast continent-sized country with huge disparity, territory, ethnic, socioeconomic inequalities, etc. A challenging epidemiological profile which combines diseases of so-called developing nations, such as parasitic infections, neglected tropical diseases, mosquito-borne diseases, and at the same time, so-called diseases of developed nations, such as chronic non-communicable diseases, cardiovascular disease, etc. The system, the public health system in Brazil is free to the point of care, although it's organized at federal level. So Brazil is a federal country, and so the system is in theory centralized in terms of the guidances, but at the same time flexibility is given to the implementation of policies at the municipal level. It's important to note that the system has been chronically underfunded and under-resourced, and is currently facing an attack, a privatizing attack on it that shakes its very foundations. Now, you may have become familiar with Brazil's president, Jair Bolsonaro, who is a populist of the worst kind, in the sense that he's a populist, an incompetent, ignorant populist. His response to the crisis has been marked by a mixture of denialism, incompetence, political instrumentalization, the use of the pandemic for short-term political gain, attacks on his opponents, attacks on the WHO, attacks on multilateral institutions, scapegoating, peddling of unproven therapies like hydroxychloroquine, going against the advices of his health authorities, for example, repeatedly leaving his palace and socializing with his followers without using masks. Everything that you should not do in a pandemic, he's done it. Brazil has had 2 health ministers leave the post during the COVID-19 pandemic. 2 health ministers have left in disagreement with the blatant inaccuracy, incompetence of Bolsonaro's response. Brazil is currently without a health ministry for 50 days, more than 50 days, 50 days. Brazil has not had a health minister. It only has an interim health minister who's recruited from the military. So all of this, what this means in practical terms: complete lack of leadership, complete lack of coordination, confusing messages. You have the federal government saying one thing, you have state level governors saying other things, you have then the president going against what the state governors are saying. You have municipal level trying to adapt, adjust, improvise in the absence of coordinated response. A disarray on the front lines of the response. And my research looks in particular at the community-based response, community health workers, and what we've observed is that the situation can be described in one word: chaos. There has been no clear, concrete guidelines as to how community-based responses should be done during the pandemic. There has been no specific training provided to, at federal level, provided to community health workers about, for example, issues such as how to avoid becoming infected or how to deal with people who are already infected. According to a survey that some colleagues of mine have done with community health workers, this is a survey by Gabriela Lotte and others, only 9% of the community health workers had received personal protective equipment. So mind you, these are community health workers. Their job is to interact face-to-face with communities. Their job is to go to people's homes and carry out primary health care, disease surveillance, disease prevention, health information activities. And if they don't have private personal protective equipment, this means they are at great risk of becoming infected. They are at great risk of becoming spreaders of the disease, becoming a vector of the infection and spreading it to their communities and to their families. So the situation is very dire, the situation is very complicated. And even though there has been some resilience on the part of the lower levels, and the community level of the health system was able to adapt, adjust, employ makeshift solutions to try to fill the gaps left by the central federal government. There's only so much that these community level responses can be done. So I think here what's happened is a situation of a political failure at national level, which in turn has been conditioned by these broader issues of global health governance that I've highlighted at the beginning of my presentation. Okay, just to wrap up, we have, I think there are a number of issues here surrounding the politics of the pandemics in the COVID-19 case. Clearly, one of the things that we need to learn from this is that populism does not work in epidemic response. It doesn't work in other things, so I'm not going into there, but certainly in epidemic response, populism does not work. Why? Because populist leaders are by their nature insecure. They frame all problems in terms of tests to their popularity. They see all political strategies, all political calculations as to what will get them the most immediate, the short-term gain. So this is not conducive to a long-term sustainable response to an epidemic and a pandemic of this nature. There's also the problem of how to ensure that there is a significant degree, and particularly in health systems such as Brazil's or in federal countries, how to ensure that there is sufficient central coordination, and at the same time that there is sufficient flexibility at municipal level, at local level, to ensure that the system is able to respond to the needs of local populations. It's a difficult balance to strike, but that's one that COVID-19 has struck into stark relief. And I think it's a lesson that countries like the UK also need to learn. How to ensure that there is a clear message coming from the center, while at the same time ensuring that the teams have sufficient flexibility to respond to different situations. Finally, I think there's also a question here, and this comes back to James's slide, how to maintain the regular functioning of the health system in a situation of pandemic, in a situation of emergency. These other problems are not going to go away. These other problems, such as, for example, cancers or maternal health, etc., they will have the potential to only become worse in a situation of pandemic. Now the question is, given the issues with physical distancing that have presented challenges to health promotion activities, to primary healthcare activities, how do you do medicine? How do you do healthcare? How do you deliver healthcare in a post-COVID-19 era where interaction between health workers and the users of the health system is a risk and is at the root of the problem? How do you ensure that you maintain interaction, that you ensure that people who are most vulnerable, people who are most remote, are able to access the health system? And a lot of things have been said about digital health, about telemedicine, about all of these remote health instruments, and certainly these can be part of the solution, but I don't think they will be the only solution. We're still going to need interaction, face-to-face interaction, because there's still many vulnerabilities, specific vulnerabilities and specific inequalities. Not everyone can have access to the digital economy. Not everyone can have access to the digital health. And we need to think about how we're going to rethink healthcare in this situation in which our traditional modes, the traditional model of delivering healthcare, which is one of proximity, has been put into question. Thanks very much.
Great, thank you. I have one question for the whole panel. So if the strictness of lockdown has any effect that we can see in the data, so I'd like to ask if the strictness of lockdown has any effect that we see in the data as opposed to just the timing of the lockdown. I'm not sure if anyone wants to start by answering that. I can post it in the chat.
I mean,
fair enough.
I don't know off the top of my head, but there are studies that have looked at, they've tried to model, what's happened to that R number across countries when different aspects of policies have been implemented. So there is some evidence out there, yes, but I couldn't comment off the top of my head. But there's definitely bits and bobs out there. But as I was saying in my talk, it is difficult because there's a timing factor, and a lot of countries have done the same thing at the same time. So it's really hard to pull apart the various mechanisms behind it.
Yeah, I mean, I showed a slide on a study that's only in preprint, which is, a really important caveat, of course, that shows various relationships between not only the timing of lockdown and also the degree of lockdown, according to a author sort of based index of the strictness of lockdown, you might say, and the relationship between those sort of things and then what subsequently happened in that country in terms of the number of cases, but also the number of deaths as well. So, but as I think a number of the speakers have pointed out, it's sort of a balance, isn't it? It's a balance, but there has to be a balance here. I don't think anyone thinks we can stay locked down forever, and that's unrealistic. And it's about how we manage this balance, isn't it, between locking down early enough and heavy enough to mitigate, for example, deaths, and try and keep morbidity and mortality as low as possible and the impact on the health infrastructure as low as possible for as long as possible, but at the same time avoiding, for example, non-COVID, or try and minimize non-COVID related morbidity and mortality, as we've already talked about, and then also the whole economic aspect as well. So it's a really complex equation. It's very easy to simplify it with a slide, of course, but it's highly complicated. And does anyone really have does anyone who doesn't have a big ego really have the true answer on this? I really don't think so. And no doubt a lot of emerging research evidence modeling in various ways will help guide us, possibly within this pandemic and hopefully for future pandemics as well. Yeah.
I agree that it's quite hard to answer this question because you can't isolate the time and the strictness, because there's no experiment on that. But I want to show one slide. Is that okay? Because I've showed this slides before to others. This is the lockdown measures taken by China and the UK. And if I make it larger, actually lockdown in the UK is in the middle of the trending line here, and the lockdown of the China is quite early on the pandemic, and the strictness obviously is more strict in China than in the UK. So if you see the peak of the pandemic in China is 12 days after the lockdown. In the UK, 16 days after lockdown. So definitely, I think in this case, both the timing and the strictness play a part here, and it's quite hard to isolate both of them.
Okay, thank you. I think Lewis had a question to ask.
Yeah, can you hear me all right? Is that?
Yes, good.
Yeah, bro. Well, thank you everyone so far for your answers and your statements. It's been brilliant listening. It was a similar question, really, but on slightly different scope. Was the science there for a lockdown earlier? I mean, we've mentioned obviously, sort of looking in hindsight, that an earlier lockdown could potentially have saved lives, but was the science there at the time, and was there sort of a delay in the government's response? And also just looking at it in a slightly different perspective, what about face masks? Was the science there earlier that for them? Because obviously we've still not had the law come in for them, and we're almost at the end, it seems, or a lot nearer the end as to we were with lockdown. Thank you.
Well, I think from my own perspective, I think it's more of politics here rather than science, because I think China went through this kind of crisis much earlier than UK and the States as well. And the China's experience has already shown the world that early lockdown as well as face covering are quite effective to control the virus, control the spread within just 1 or 1.5 months. Even so, like China has done so, still the UK and the States in particular were reluctant to do the similar things as China did, because they consider, I think, it's more a politician thing, because they think all the stuff China did are all dictatorship rather than democratic measures. So they were reluctant to accept the ways that China did it, even though these measures were right.
So, else got anything to add?
Yeah. So I'll try and say something. Sort of, was the science there? Well, it's sort of interesting because, you know, I completely agree actually with what she said. You know, at the end of the day, there was some evidence emerging from China, maybe not published evidence per se, but there's certainly some experience available to guide other countries. The video I didn't show, Mike Ryan basically says, you know, one of the things the WHO has, I think, very visibly learned from the Ebola epidemics is that if you don't go in quickly and hard, then you're going to get burned. That's the bottom line from the experience from Ebola epidemics in Africa, of course. And also another thing that I think is really interesting that he said, if you go and look at the video, is he said that if we go for an approach that aims for perfection, then we will be paralyzed. And the problem is in an emergency situation like this, actually speed trumps perfection. And so you do the best with what you know at the time quickly and hope it's effective. And if it isn't effective, then you reflect on that later and learn the lessons. And I think that's something we really need to sort of do. I mean, we all have our opinions, but what's really important, I think, is we reflect on the experiences and synthesize them in a robust way, a meaningful way that then informs global society moving forward. And, you know, at the end of the day, we have evidence about lockdowns from 1918. And of course, you can't extrapolate from flu necessarily to COVID. Obviously, everyone knows that. But nevertheless, there are interesting contemporary publications over the last decade or two that have looked at data from 1918 and showed really interesting results that, you know, could have informed some countries' approach. And of course, I think a lot of countries, or some countries anyway, not a lot, but some countries got sort of a little drawing into the herd community thing, and also the herd immunity thing, and then also, you know, obviously, you know, the evidence from flu pandemics previously is how hard you lock down. If you lock down too hard, then you can get, you know, and then open up too early, you can get quite a large sort of second peak, and who knows what sort of second and third sort of wave we're going to get now, say in the UK, but let alone globally. So this is all really complex stuff, but I agree. A lot has been driven. My perspective, and I'd be happy to be proved wrong about this, but my perspective is a lot has been driven by politics and also pragmatism, because it's really interesting. I was working in the coalface really early on, and really early on within the hospital setting, we were really concerned that if we overused PPE in a certain way, or if and inappropriately used it too much, for example, early on, that we would get to the peak of a pandemic, of our country pandemic, and then we would have no PPE, because that's actually what it looked like early on. It looked like we would run out of PPE at some stage early on. So there has been an element of pragmatism here at the ground level, in terms of, because our perspective early on was that we didn't have endless PPE in the UK to just use willy-nilly in February and March. We just, that was very much the coalface level. So we were actually trying to use it quite sensibly and in a balanced way. So issues like that have definitely impacted. To be fair to the government, I think issues like that have definitely impacted how we responded. Now, of course, the question is about preparedness. Should we be really, in a relatively rich country like the UK, should we be really in that position? And I think that's a whole other debate.
Should I go on to the next question, or has anyone else got anything to add?
Can I add something on that? Because I think yes, actually science, dealing with the pandemic, the COVID-19 is really a complicated issue. It concerns health, economy, society, etc. So when you're talking about science, it's quite hard to define what kind of science it is, because the science may only focused on health issues, or the other science is mainly focused on economic issues. But the government in itself needs to consider all these kind of different things. So I think that's why I think the response by the governments are not really wholly based on science, because science in itself is too limited as compared to the things that are faced by the government. Yeah.
So one final question. Has anyone looked at the Google metrics about compliance with lockdown and the spread in different areas? All right, start.
I'd be very surprised if someone hasn't, but I'm not familiar with the data. That's all I would say. Yeah. Maybe you should Google it. If you Google it, I think you might find something. Yeah.
I haven't looked at the Google metrics about the compliance with local lockdown, but I've seen some graphs about the density of the travel in the UK, in London, as compared to Wuhan, the epicenter of China. And you can see the declining trend in Wuhan was much, much more dramatic than the declining trend in London. So I think on one hand, it might be due to the strictness of the measures taken by China. On the other hand, I think Asian people, Japanese, Koreans, like Confucian culture circle, got more this kind of compliance with the rules as compared to the Western culture. So yeah, that's sort of.
If no one else has anything to add, should we end it there?
I'd like, well, if no one else wants to, are there more questions? Oh, sorry. Because I wanted to say something if no one else wants to ask any questions, which is to thank our chair, Bella. I know this is your first time chairing an event of this nature, so well done. You've done a great job. I hope this is the first of many. So thanks for chairing. Thanks for organizing. and well done.
Thank you. Thank you to our panelists. That was really interesting. Very, very insightful. Thank you for coming.
Thanks. Bye-bye.
Thanks for the invitation.
Thank
Take
you.
care.
Bye.
Thanks very much from me too. Thanks everyone. Bye.
Bye.